Believe it or not, men have health issues too. Tonight, we'll take a look at men's health and what they can do to improve it. It's well known that men just don't seek medical care as often as they should. Part of it is a macho, I can get through this attitude, but part of it's the self-secure feeling that they can take care of things. They are the fixers, the caretakers of the family and themselves. We will work to address this disconnect between beliefs and needs tonight. First, let's take a look at this week's Prairie Doc quiz question. The most important risk factor for the diagnosis of aortic aneurysm is A, age greater than 65, B, history of having ever smoked, C, being male, D, all three. We'll answer the question at the end of the show. Joining us tonight from Avera Medical Group Pierre, a department of Avera St. Mary's Hospital, Pierre, South Dakota, is Dr. Ken Bartholomew. Ken, tell us a little bit about your background. Where are you from originally?
I grew up in Lemon, South Dakota.
You're a Lemon, South Dakota boy.
Yep.
That's a town of how many?
Probably about 1,500 now.
Yeah, size of De Smet. Yeah.
And then I went to pre-med and medical school at University of Utah, did a couple of years of post-grad training in Southern California, and then went to Falkton, South Dakota.
So your med school was at Utah?
University of Utah, Salt Lake City.
Yeah. And then you practiced in Falkton for how long?
14 years.
As the only doc?
Pretty much the whole time. I was the only doc in town, and really didn't have PAs much back then either. I trained one, but then after a while, I just got tired of being on call all the time and moved to Pierre.
And that's been good?
Very good.
There's a few characters you have to work with, but other than that, I mean, you know.
It's true.
That's good.
No names.
No names. Also in our studio is Dr. Eugene Park, Urology Specialist, Sioux Falls, South Dakota. What is your practice? You're practicing urology. Where did you start?
From a town called Rockford, Illinois. It's just on the Wisconsin border. Did my undergrad at Northwestern University. Went to medical school at University of Illinois. Did my residency in Omaha, Nebraska, and then I spent 2 years in California and came to Sioux Falls.
You practiced in California.
Mm-hmm.
You were married at the time.
Engaged, and we got married about a year into it.
And then you were in California. I mean, this fabulous spot in California. What happened then? You came back to South Dakota.
Yeah, but my wife got a little homesick, and we had a little girl, and decided it was best to be with the family, so kind of moved back here.
You know, the idea of raising a family in South Dakota, kind of hard to beat that.
Yeah.
So this is a story about men's health today. But really, if you think about it, men's health is anything and everything. As a urologist, you deal mostly with men, although you have some issues with women. Do you, how many men versus women in your practice, Ken?
In family practice, it's kind of 50-50. We see everything, pediatrics to 100-year-old patients.
Do you do nursing home care?
I do. I'm a medical director at 2 nursing homes, one in Falkton and one in Pierre.
How many nursing homes in Pierre?
There's 2.
2. So, if you think about men's issues, what do you deal with more than anything on a daily basis or a weekly basis?
On almost a daily basis, it would be high blood pressure and how it relates to heart disease, stroke, aortic aneurysm, prostate issues, sexual dysfunction issues.
Which is it's an issue.
It's an issue that usually we have to bring up, because they don't want to bring it up, but once you ask the question and open the door, then they're willing to talk.
How much sexual dysfunction issues do you work with, Eugene?
It's pretty common. Gets more common as the man gets older, and so kind of overlaps there with your practice, but they're not so shy but once they come to us.
Yeah, they've been through it. They've
yeah.
talked, finally somebody brought up the issue.
Yeah.
I found that true too. They don't bring it up unless you bring it up. What age do you think people, let's just talk sex dysfunction in men for a while. What age group do we see the most with that? I mean, we see more often in the elderly, but when does it start happening? Let's put it that way.
You'll see a small percentage actually in their 20s and 30s. It's a very low percentage, but as each decade goes up, you'll start seeing an increase. And once you hit around 50, 60, it starts getting more and more prevalent.
And what's the most common cause?
I think a lot of it's multifactorial. It's going to be some vascular issues. Hypertension certainly is going to contribute to some of that. Some of it's diabetes and neurogenic issues. So it's kind of a multi-cause.
Smoking. Smoking is a big factor. And alcohol. Too much heavy drinkers. Ken, any other thoughts on that?
No, I think you hit it right there. It's substance abuse and lack of
Healthy lifestyle.
Right. You know what I think too also is vigorous exercise, I think helps directly protect
That whole system.
Right.
So I'm a fan of exercise, and it for many, many reasons, but that's certainly another one. I mean, it helps with the sexual dysfunction. So I think when I address it, I try to bring people to their healthy lifestyle. What about medications? And testosterone levels? That's a good question.
The big T.
Yeah, the big T.
Testosterone's kind of a tricky issue. I think a lot of people know about it because of all the advertising. I think some of the companies are getting in a little bit of trouble for all the advertising that they've done without any backing. But testosterone is just a portion of control of the function. I mean, the psychology has to be there, the nerves have to be there, the hormones have to be there, the blood supply has to be there. Medication-wise, there's several options, and they're all good options. There's the Cialis and the Levitras and the Viagras. Those are probably the big three that most people know. So it's a reasonable place to start.
And then another point is, if you're already on some blood pressure medications and then you start having erectile dysfunction, it's really important to look at drugs first. A lot of times you got to take away drugs and change drugs because sometimes it's pharmacology that's causing it.
Same with antidepressants.
Antidepressants do cause it, but not, I think, a minor amount. Nothing like some of the blood pressure pills. And certainly nothing like alcohol and tobacco. Those drugs will kill it. But let's talk about T. When do you measure testosterone in a guy?
For me, it's kind of a last resort. I want to make sure everything else is functioning. I have to make sure that they're truly symptomatic. I mean, a lot of guys think that just because they don't feel like they were 18 anymore in their 50s, they have low testosterone. But I'll screen patients occasionally just to get a baseline level. But
do you do a serum testosterone, just a plain? It doesn't have to be fasting.
I actually do fasting. There's a doctor up in Michigan who actually recommends getting a fasting testosterone. He thinks it's a little bit more accurate, so I'll ask them to get a fasting
early
level.
morning
Yes.
is better.
Yes.
Okay.
So it's timing. You don't want to come in at 5:01 and get your blood drawn after a long day at the office or something. 'Cause it's not as
It'll be waning at that time
Testosterone
anyway.
peaks in the morning, so.
So let's ask that question. So let's say the normal levels are between what and what? 30 and...
Depends on the lab, but for total testosterone, usually 5,300 to 1,000. So it's not a very tight range.
Right.
Right.
I was thinking 300. So if you get somebody in the 200 range, 150 range, clearly low, do you just say, okay, well, the treatment is therefore I'm giving them testosterone, or do you have to kind of look at pituitary and do other things?
I will check more the hormonal axis just to make sure there's nothing more global going on first.
So explain that.
So I'll check some regulating hormones, something called FSH and LH, and if I'm concerned, I can always get a PTH for the pituitary to make sure that's not causing adjustments. Because if there's something more global going on, you can always try to fix that. And that will also give you an idea if something's going wrong with the testicles, which is what's primarily making the testosterone. But I'll do that before I start anyone on testosterone. And again, I have to make sure they're truly symptomatic. The other thing I will do is I will screen all men before starting for prostate cancer, because testosterone and prostate cancer is a very bad combination.
So some people may have high testosterone, or if you start replacing and they have prostate cancer,
It's like adding fuel to a fire.
Fuel to a fire.
Yeah.
So that's one of the dangers of giving testosterone.
Right.
Correct.
Any other things to add?
The other thing, one other thing I always check is thyroid, of course.
Yeah.
And so if you give somebody a medication to replace a natural hormone, it shuts down their own production.
Right.
So you got to be careful about that. If they're just borderline low and you start giving them a testosterone dosing,
they stop their own production.
Shuts it down, and now that's probably not going to come back. Maybe it will with time.
Yeah.
But so before I ever do that, I really push them on the vigorous exercise. Weight resistance exercise has been shown to increase.
Weightlifting raises your testosterone.
Weight resistance exercise increases testosterone levels.
Just weight loss will increase testosterone levels.
And then if that all fails, then I send them to the urologist. I usually don't start them on it
really
without a consultation.
Yeah, I kind of go over them, looking at their axes, their endocrine axes, making sure that they don't have something else out of whack, and then consider the shots, because that's way cheaper than the other options. I really don't prescribe the other methods. But to a person who's got a low level, it's kind of nice to give them replacements. Some people really appreciate it. Mm-hmm. So let's move on to this. There is an old Three Stooges joke where Larry is accused of snoring. He answers that it isn't true because he stayed awake all night to check and never snored once. But snoring is serious and can be an indication of a dangerous breathing problem that requires treatment.
They said it was obstructive sleep apnea, and that his throat was relaxing so much that his tongue was falling back into his throat, and he was stopping breathing. I was waiting for him to take his next breath during the night, because I had laid awake waiting for him to breathe, because he would stop breathing all the time. And he snored very loudly. He had a reputation for snoring.
Well, if we have company during the day and not sleeping too good, I would fall asleep visiting and wake up again. I don't do that anymore. I get rest at night like it's supposed to be.
They had electrodes all over. They were checking his eye movements. They had the brain waves, the heart, and his legs. They were checking for restless leg syndrome and stuff. And when the guy came in and was reading that, we heard him say, "I cannot believe how this guy stayed awake at night driving truck." And we told him when he came in, the reason that he did was because we prayed every morning or every afternoon before he went to work. He drove at night at that time. But it was truly a miracle that he did as well as he did, because he stopped breathing over 200 times in that first hour. So they just took all the electrodes and everything off and put the CPAP machine on him. And the next morning, he had tears in his eyes. He said, "I have never slept so good in my life." And he has been on that CPAP machine over 20 years.
There's a long hose, and then this mask is fastened, and it's like a nightcap, and it comes just above the lip. I just sleep real good.
But I didn't care that the machine made noise. He was breathing. That was the important thing.
Well, with that first machine, I got the adapter for it that we could plug it in the cigarette lighter in the car, in the van, as our daughter was in Texas, and we'd drive straight through and took turns driving, and I would lay back there and sleep with my CPAP machine. I don't leave home without it if we go anywhere. When I get in bed and pull the covers up over me, when the light goes out, my eyes go shut, and that's it.
He's much more active and stuff now too. You can just tell he's just like a different person since he's gotten a good night's rest. Oh, I sleep a lot better too, because I know he's going to wake up with me in the morning.
That's one of those cases where a brilliant diagnostician, comes to the fore. I was in the office with him and her, and she said, "Do you think he could have sleep apnea?" And of course, he snores and then he does these pauses and doesn't breathe. I'm worried about him, and I went, "Duh." And I think he was really the first sleep apnea case I've had. I can't give myself credit for making the diagnosis because Mrs. Buse did. But the great story is that it just made a huge difference in his life. And I know the Australian studies say that over a 13-year period of time, those who have moderate to severe sleep apnea have a 33% death rate if they're 30 to 65, and those who don't have a 6% difference. It's like 10 times more important than any cholesterol issue. And I think for vascular disease and heart disease. So what do you think, Ken, about sleep apnea?
It's absolutely true. I've got a friend who he'll come through town and it'll be getting late at night, and I'll say, "Well, why don't you guys just spend the night?" And he'll say, "No, I didn't pack my CPAP machine," and he says it's not worth it. He said, "I'll just drive home the 100 miles because it's that important to have it at night."
Yeah, I mean,
one patient made the comment that was just like eye-opening to me. She said, "Even the colors are brighter." Her brain was that much more awake.
Right, and the issues of how sleepy they are during the day, and the sleepiness goes away. The fact that they're more alert, they feel better. I think that's a huge deal. So tell me about CPAP. I mean, there's these other methods, the jaw things and devices and so on. Do you recommend those?
Well, they can always try them because they're worried about the cost and everything. And if you have a real mild case, some people report that those appliances help. But for the patients who have anything beyond moderate sleep apnea, they're going to do better with the CPAP.
And how does it work?
Well, kind of imagine you've got a balloon and you blow into it and it opens up, but then you suck back and it collapses. Well, your throat's doing that all night long when you breathe in and out.
Right.
And especially if you have a thick neck, if you're overweight, have other issues. And so then it collapses and you're in a deep sleep and you don't really notice it until you run out of oxygen and your carbon dioxide builds up. And then you do one of those, and you stutter breathe, or you actually wake up. You may not know you're awake, but your brain is coming up out of REM sleep, and so you never get that deep rest. You're constantly up and down all night.
And so it gives you pressure so that your balloon never
open, right?
Yeah, the balloon is always open. It's just giving positive.
Right. So it's positive airway pressure is the continuous positive airway pressure. That's what it stands for, and it's always blowing that air in. Now, some people who have advanced lung or heart disease, they'll actually bleed oxygen concentrator into that to give that extra oxygen, but most of them just need that extra air going in and keeping that airway open
to stay
make
open.
the difference.
So explain a BiPAP.
That's a little different. That's bi is 2, okay? So there's an inward and an outward pressure change, kind of helping you breathe.
So it's almost like being on a respirator that's breathing for you, but you don't have the tube down the throat.
Right. In fact, it's gotten so well refined now that we actually use it in ICU patients, who we used to put on a ventilator.
Yeah, we'll put
we
the
can
breathing
put
tube down.
Slap the BiPAP on them and kind of bring them around.
Bring their oxygen, breathe for them. So the machine actually does the breathing for them.
Right.
So the difference between an obstructive sleep apnea and central apnea is what?
Well, the obstructive is
That airway thing that you just
that's
explained.
the local collapse of the airway. Central means that your central nervous system is just not signaling correctly.
And that's when the BiPAP is really best of all. I heard that used to be called Ondine's curse. Have you heard that one? Ondine was the myth.
That goes way back. Yeah.
Yeah, the myth where Ondine was so. I think Ondine was the guy who he had made love with one of the god's daughters or something. I don't know what the story was, but the god was mad at him. And so she took away his natural drive to breathe so that whenever he fell asleep, he would die. Well, he stayed up for a week, you know, and couldn't stay awake and finally fell asleep and died. And that's the story of Ondine. And that's really more like the central apnea story rather than the obstructive. And he would need the BiPAP.
Right.
Right. So,
Well, another point about sleep apnea is not just the feeling better the next day. I mean, that's obviously important, but it causes high blood pressure. It causes heart failure. That low oxygen all night causes all kinds of cardiovascular complications, and so it can actually not only make you have a better day, but it can make you have more days.
yeah, I know that when you are obstructing and you have hypoxia or low oxygen through the night, you have increased it ages you faster. It's increasing
Absolutely.
aging right there in front of you. So it's an important issue, and I think about obstructive sleep apnea or sleep apnea when should we suspect it? What should the wives? It's more men, but it's both women and men.
About 3 to 1, male to female.
When should we suspect sleep apnea could be the problem?
Well, I think that anyone with when you're doing a workup for high blood pressure, irregular heartbeat, such as atrial fibrillation, which 1 out of 10 people is going to get in their lifetime. I mean, it's that common. Heart failure, and maybe a sudden heart attack. I think all those people need to look at it because it's very much underdiagnosed, I believe.
And strokes and it's
Strokes,
just vascular
yeah.
disease. This is the big.
All
it's the big deal.
vascular.
The study in Australia was the deaths from all causes, including cancer, but a lot of car accidents.
Yes, huge.
Huge car accident.
Falling asleep.
Our patient was a trucker, and it scared me when I heard that, and his wife said, yes, this is an important point. So, but it's remarkable how well this man has done, and for so long. Well, there's a lot of things that we can talk about. We can switch back to issues of the urologic sort. And let's talk about benign prostatic hypertrophy, Eugene. Guys get older, their flow changes, they can no longer, pee over the barn. Is that how whatever it is that they use?
And peel the paint off the barn.
Peel the paint off the barn.
I've heard that a couple times.
So tell us a little bit about benign prostatic hypertrophy.
Benign prostatic hypertrophy refers to the enlargement of the prostate. The prostate sitting right underneath the bladder. It actually kind of hugs the urine channel, kind of like a donut.
So let's just draw a picture of it. So here's the urine out, and then it's sort of like an apple that goes around, and
It goes right through it.
It goes right through it. So this is a side view, and if you looked at it from here, from above, it would be going through it.
Right. So as every man gets older, starting around the age of 50, that tissue starts crowding in on that urine channel, and it creates a physical blockage. And so the common symptoms are going more frequently, going with less force, dribbling after going to the bathroom, getting up at night, needing to push to urinate, Sometimes it gets so bad that guys can't go to the bathroom. They have to have a catheter placed. Not every man is going to have that degree of severity, but pretty common as each decade goes by. The chance of having problems like needing a catheter start going up.
Now, that urine flow thing, how many times is it benign prostatic hypertrophy? Benign. And how many times is it cancer?
It's very rarely cancer unless it's very advanced. The tissue that's actually causing the obstruction is usually benign tissue. And so prostate cancer tends to develop in the more outer areas of the prostate, not the areas that create the blockage. Now, if you have severe prostate cancer that's taken over the entire gland, that can cause an obstruction, but usually it's not the prostate cancer.
So the tumors are oftentimes in the outer side of it,
Yes.
out here in the rings. That's interesting. I hadn't realized that. So the benign prostatic hypertrophy, do we need to do any major diagnostic tests aside from echoing the bladder and make sure that it isn't full? I mean,
Yeah, a
tell
lot
us
of
about that.
people will have what's called a bladder scanner these days where they can check how much fluid is left in the bladder after you go to the bathroom, and that's an indication. You can actually measure the flow of the urine and see how fast it is. We have ranges as far as what we expect most men can achieve as far as how quick the flow is. A lot of it's just based on the history, though. It's pretty apparent usually. Now, it could be, the symptoms could be due to what we call an overactive bladder, where the bladder is irritated and starts quivering and starts making you go more urgently. And sometimes the enlarged prostate can actually cause that. It's sometimes difficult to tell the difference between the two, but in either way, you usually start by relieving the obstruction first, seeing what happens.
So there are several ways to relieve that obstruction. What would be the way?
I think most commonly these days we start with medications. There's something called an alpha blocker. I think Flomax is one of the more common ones that most guys are familiar with. It relaxes the muscles of the prostate, just makes it easier for guys to go. There's a medicine.
It's pretty quick.
Yeah, it usually works within a week or so.
And it works right in this region. I mean, let me just,
Just draw
it
that
cleans
circle
this.
a little bit wider there. It
Makes this
that-
wider?
Yes, makes it a little bit easier to go.
So, and there's muscles that surround this. That's what you can, are the muscles to stop and open the flow
Yes.
within there, and it relaxes those muscles and allows the flow.
Right.
Do people have leaky bladders because of that? type
No,
of
the
medicine?
muscles that keep people dry are actually sitting in front of the prostate and right at the neck of the bladder, so it doesn't usually cause leakage. Some guys, it opens up the obstruction, their overactive bladder takes over and they start going more frequently, but that's not common.
Okay. How important is nighttime urine? I've got to go to the bathroom 3 times during the night. I have to get up 5 times during the night. I mean, how important is that history?
It's pretty important, but it's very subjective. Our guidelines ask us to check for the bother symptoms on people. Some people get up 3 to 5 times a night, they don't care. I've got other guys who get up once or twice and it just drives them nuts. And so, as long as they're not having problems with kidney failure or their bladders aren't paralyzed from too much damage from obstruction, you can actually let them go. So a lot of times I won't treat people unless they tell me they have truly bothersome symptoms.
And you see a big dilated bladder after they've emptied their bladder and it's still full, then you feel that there's. So we've talked about alpha blockers. There's also other treatments for prostate hypertrophy. What would that be?
There's a medicine called dutasteride or Avodart and Proscar or finasteride, and those drugs will actually shrink the prostate. They block the conversion of testosterone in the prostate. And those drugs will actually shrink the gland down, and it kind of makes the gland itself smaller so guys can go to the bathroom better. A lot of people will actually combine the two. The two will work better in conjunction with each other.
New England Journal of Medicine article showed that definitely 1 + 1 is 3.
Yeah, and a lot of times you can actually get off that Flomax medicine as time goes on. Once the gland has shrunk, you can try to do just one. Some guys have to do both.
But like you say, the finasteride is gradual, slow, and it makes everything shrink. The
Flomax
is real fast.
Yeah.
But it loses its effect over time.
Yeah.
So
What is the research showing on the potential for increase in the aggressive tumors with that?
That's always been a debate, and I think most people will tell you they don't believe that finasteride or Avera causes high-grade prostate cancer, I think what's happening is that those guys probably had prostate cancer, and you shrank the gland down and made an easier target to detect them.
Right.
And so
we're going to come back to this. Sure. I want to ask about Cialis for the prostate hypertrophy.
Sure.
That's another thing. And the complications of finasteride and Flomax. But we need to do this. We have a choice to choose among our options every day. Some of those choices are harder than others.
She says, you know, there's this test. It isn't always reliable, but let's just do it. And, you know, so I've had 3 or 4 years of those results. And every year it's gone up a little bit. And she, knowing that I get a little anxious when it isn't quite right. And so that's how I got to see Dr. Parks. And so we got to do a biopsy, which is really a fun experience. That's not true. That's not true at all. But anyway, we did a biopsy and came back that out of 12 different samples, 6 of them had a Gleason score of 6, which, as he says, just remember that 6 is at the low end of having really some problems. You'll have to go home and decide and do some research and decide. I'll help you guide through that. And he says, come back, ask questions, and we've done that a couple, 3 times. Went to an oncologist, cancer doctor, oncologist, and he says, you know, you're not going to need my services, but yeah, you'll still have, you have that possibility, yeah, you should do that surgery. Yeah, you have your choices. Yeah, you have radiation. Right now, what the procedure is, the normal procedure is that you can go and it's like a half-hour procedure for 6 weeks every day. And when you get done, the same results will happen. It will kill the cancer. That's the ultimate goal. But you'll still have the same complications as the surgery. So you can go have surgery, and this is done with one of those robots, which makes it, as he said, you know, in the olden days, surgeons could do just as good a job, but nobody's doing it that way anymore because it's it is faster healing by having small incisions than the big open whatever they did before. So then you can have surgery. Okay, so the complications are afterwards aren't great, but you know, you in six weeks we'll be able to find out how complications there are. You know, will you gain your muscle control of your bladder again, and all kinds of fun things that area controls. But he says, but we have things to help you with if that's the case. So those are the 2 main things, the radiation and the surgery. And he says, I know I'm a surgeon, but I'll say what I think about that. And he says, if we had surgery, okay, and we miss something, or something happens, well, you just don't have surgery again, but you can have radiation, and it will finish the job. But if you had radiation, then I'll have to send you to like Mayo because we need a different kind of surgeon because the tissue will be not easily sewn or cut. Well, probably cut's all right, but sewn back together again, so you'd have lots of trouble. But both are very good procedures. So when you're young and able to handle the surgery and all that stuff that's going to happen, hopefully my body's young enough that it can just go on. Okay, so then you find out, okay, now I'm 75 and diagnosed because things stopped working or whatever happens. But obviously the cancer could spread, even though it's slow growing. And now I'm going to have surgery. And my body's worn out a little bit more. And so the procedure is the same, but now your whole system is slower it's hard to get back on your feet. I mean, that's kind of what is talked about, because they caught it early in me, that I have a chance to actually do something about it.
You know, it's a courageous thing for somebody to stand in front of a camera and talk about cancer that was just discovered in them. So I thank you for doing that, Clark. So he was your patient.
Mm-hmm.
And he talked about that you gave him all the options. He got another opinion. He did all the studying, and I can tell you, he did a lot of studying. I know that. And he's going to have that procedure done after he goes on a sailing trip in the Mediterranean.
Sure.
That makes sense to me. Well, what lessons were important that Clark had described there?
I think he really touched on an important point about the age issue. And that's something I didn't really concentrate on during residency, thinking about people's age. But the younger you are, the more life expectancy you have in front of you. And there's a lot of controversy about whether prostate cancer should be even checked for, should we be screening for it. You know, if you live long enough, most men will die from it anyway.
Or have it.
Yeah, die with it, I'm sorry.
Die with it.
But people don't think about what it's like to have advanced prostate cancer. And it's not something that we see much anymore. And that was eliminated almost exclusively with the PSA. We probably have taken out too many prostates over the years, just because we could find it. Starting in the 80s when we had the PSA, we could detect it early. Before that, we would have to wait until we had pretty advanced cancer, and maybe once in a while we'd be able to stop prostate cancer from getting aggressive. But you know, I tend to think about the age factor. If people are younger and healthier, I do tend to push for an aggressive treatment because they don't want to have metastatic disease in the bones or bleeding in the bladder. So there are some other benefits to doing the surgery other than just
right.
cancer control.
Yeah. Ken, any comments about that?
No, I've seen several patients die of metastatic prostate cancer, and you know, my first one was in his 90s, but one of them was only around 70, and that's too young when it's spread to all your bones and have a lot of pain and everything. So
I had a physician patient who had metastatic prostate cancer and died from it. And he had a prostatectomy.
Sure.
I mean, it doesn't guarantee anything.
Mm-hmm.
And I've had patients die from complications of prostate surgery.
Sure.
So it's a tough issue for me because I've had those experiences. And I'm a little less inclined to do PSAs.
Sure.
But in a younger man, when you discover it in a young man like this, he is at higher risk, and particularly with a family history of cancer, gosh, I think it's exactly the right thing.
Sure.
And he struggled with it, and that was good.
I think it is important to bring up for the listening public that when the PSA test first came out, we thought, man, this is golden.
Yeah.
And so we were doing it every year, and we were sending a lot of people for biopsies that would never have gotten a biopsy before that. And one of my patients almost died just from the biopsy. He became septic, his blood pressure crashed, he was in the ICU. It was nip and tuck for a few hours, just from a, quote, simple biopsy.
Well,
so
you go through the rectum.
You go through the dirty rectum to get at it.
It's not a clean area.
And so the public or the health services task force weighed all that information, where they gleaned all the information for 10, 20 years, and they found out that basically for everyone we thought we were helping, we were probably hurting one. And they're saying it's kind of a wash, so let's not be so aggressive. And that's why we've backed off and not doing the PSA every year.
Right. I believe in the digital rectal exam. The last prostate cancer I discovered was, I'm doing a colonoscopy. And by the way, I'm going to need to have this guy see Dr. Park. And that's what I did. I set him up for for you. I've sent you a number of older people, and so it's not to say that I'm completely against the prostate cancer screening and so on and so forth. But I'm not hot on the PSA. That's how that is. But I certainly do believe that younger people in particular would a more aggressive therapy. If after 75, do you find a prostate cancer at 75? Do you?
You know, some people want to operate after the age of 70 or 75, but the real rule of thumb is if we think you have a life expectancy greater than 10 years.
Right.
I've done it maybe 2 or 3 times in the past couple of years on older guys, but all of them, I mean, they're probably healthier than I am. And, you know, one guy went biking like 100 miles before his surgery, like a day or two before his surgery. And all of their family lived to be, you know, 100, 101.
Right.
So it's a very selective thing. I don't usually recommend screening past 75. And that begs the question.
Ignorance is bliss sometimes.
Yeah, sometimes. But then sometimes you get these people who just show up out of the blue and someone checks a PSA just randomly and it's 500.
Yeah.
So it's always a dicey question. But for the most part, I will stop out. If they have a low PSA, a history of very low PSAs,
We're done.
I just go by their symptoms.
Right. Is there a lifestyle thing that a guy could do to protect from prostate cancer?
I think there is. My father had prostate cancer, and he's the first one in the family. I think the American diet has something to do with it. It's not a very common thing in Asia. You'll see that people who have less of a meat-based diet, more of a Mediterranean diet, they tend to have lower rates of prostate cancer. Everyone always asks me, is there something I can eat to change my PSA? But I think it's a lifetime accumulation effect. So in general, I tell people, you know, do a heart-healthy lifestyle. Heart disease is still more common than prostate cancer.
That's a good answer.
So,
what do you think?
I agree, and that also you have less heart disease, less colon cancer with that.
Less fat.
Less fatty prepared meats, you know, smoked meats, things like that.
The smoked meat, I think it's that nitrite that you put in there. That's been pointed as the guilty.
That causes a lot of stomach problems in Asia. There's a lot of smoked meats in Asia, and a lot of nitrites, and stomach cancer is big in Asia because of that.
Because of the nitrites.
Mm-hmm.
Yeah, there's something about that. A little bit is okay.
And I just used to love all that stuff.
Oh, that bacon?
Everything in moderation.
Yeah, everything in moderation. That's right. Well, we've got issues, you know, we can talk about in men. I want to talk about anger, because one of the things, I think there is this condition called depression. That's a real deal. I'd say a third of all human beings, male and female, get it. But it manifests itself in differently in women than in men, I would say. And that's generalities. Maybe I'm doing too many generalities, but I'm just kind of generally saying that in guys it presents oftentimes with anger. And let me just throw that at the two of you. My sense is when a guy comes in and he's been angry, I treat him with an SSRI. I treat him with an antidepressant. I don't tell them that you've got depression, but you're having trouble dealing with your wife and your family and your kids and your people, everybody's angering you. Let's look at this as an option, see what it does. What's your take on that?
I would agree. Males just handle it differently, and I think it's not just societal. I think it's testosterone.
Oh, really?
I absolutely do. We're different. We're different when we're 1 year old. And, you know, there's nature and nurture, but nature is really important. Yeah. And you watch little kids, they're different at age 1, age 2, age 3. And males just handle it differently, and they're much more, they're aggressive. That's the way we evolved. The other thing about your comment about depression, just depends on where you want to draw the normal line. Because I tell people that depression is not, our moods don't do this throughout our lifetime. Our moods do this.
Like waves on a sea.
Absolutely, and we have highs and lows throughout our life, and external and internal things that modulate those. But you know, we all have, depression's part of life. It's just part of the cycles. It's just that how deep does yours get, and how do you handle it? what's important.
Right, and if it gets too deep,
But
and
I
you're
think we all have it
if you
sometimes.
start hitting your wife, or you start blowing your top every time, maybe you need to realize too deep.
Maybe a little help there.
Yeah, the ocean. I've been sailing this last week out on Lake Superior at the Apostle Islands.
That's right.
There was no waves. There was no wind.
No wind, and you went sailing.
Oh God. We had a wonderful time, however, but we had no waves. We had no wind. But there was a lot of humor and a lot of music. We sang, we had a guitar, told a lot of
Should have
stories.
just come to Pierre and gone on Oahe, because we always have wind.
Yeah. Any comments that you would have, Eugene, about men? You deal mostly with men.
Yeah, regarding anger specifically, we don't screen too much for that. If people are angry, they're usually upset about something specific. So I can't really comment on generalities. I will say this, there's been a lot of study. We cut the testosterone in a lot of men with prostate cancer, and we have noticed people have ignored it, but depression does happen in men who we kill the testosterone on, and that's something that's becoming more of a focus
You
these
can
days.
see it. Do you start SSRI or an antidepressant medication?
I will recommend it. I mean, I think we all just kind of figured they're depressed because of their prostate cancer, but some of these guys, it's a little more than that. And if they're really feeling kind of not so well, I kind of tell them to talk to their regular doc about getting
A
that.
physician wrote a piece of my mind, I think it was about 15 or 20 years ago.
In JAMA?
In JAMA. And it was titled something like "The Loss of Passion," was the word he used, I believe. And he had gone through this. And
Lost his testosterone
Right.
from therapy.
Right. The therapy took his testosterone to nearly zero, and he said it wasn't just the sexual, it was the passion in life.
It's a tough surgery to get over. A lot of guys, I don't think, a lot of our patients get out the next day from surgery. I think they're surprised by that, but psychologically, I think it's a very tough surgery for some guys.
But
to
a prostate
get
surgery
over.
doesn't generally take away testosterone.
No, but I think it's, some of the side effects are sexual dysfunction and leakage, but just the surgery itself, even before you have to worry about it, it does cause some of that.
And Cialis, do you like Cialis instead of the prostate shrinking by blocking testosterone?
In my experience, I've kind of found it's either hit or miss.
It may work, but it may not.
Yeah, I kind of use it as an adjunct. If
Okay.
I have a lot of samples of 30 days,
Cialis,
so I'll give it
yeah.
a try. But it's kind of hit or miss.
All right. And now for the answer for tonight's Prairie Doc quiz question. The most important risk factor for the diagnosis of aortic aneurysm is A, age greater than 65, B, history of having ever smoked, C, being male, D, all three. The answer is D. All three are important. And do you have any comment about that? Do you think smoking is more important than the rest? I couldn't find data on that. I just couldn't
kind of
find
think
it.
it is, because when you look at the data about only 50 to 100 cigarettes in your whole life sets you up at higher risk.
That's an amazing.
There's something in there.
Yeah, they talk about the one screening test, doing one ultrasound between the ages of what, Ken?
Oh, after age 50, basically, if you've ever smoked.
Yeah, so a guy. So that's...
Well, females too, if they smoked. I mean, males will have 3 times as many aneurysms as females, but females get them too.
Well, and then they just die suddenly. I've had patients die suddenly from this. And now you can take a catheter in the groin, run up a stent, just like in the heart, only it's a big one, and capture it, save it, and it works, what, 80% of the time?
Just bolster it. It's like putting an internal sleeve in there, and then the other key thing is high blood pressure needs to be treated, because think of that pulse going boom, 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 75 times a minute, stretching that out. Every time it pulses, that aorta gives a little. Well, if it's an aneurysm and then it eventually tears.
In the 70s, they were talking about not doing surgery, but just really lowering the blood pressure. And they were successful.
Right.
So one big reason for controlling pressures.
Pressure, yes. I have one gentleman who's not a surgical candidate. He's just not. He's elderly and he's frail, and we've just piled on the medications, got his systolic
And he's
down
been
to
alive for
110.
how long?
And
Done great.
It's been many years now, and we just keep checking it, and it's not growing, and we just...
All right. And we'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
Talk to a man about a complicated physics type issue, and he'll often have some working knowledge about it. Ask a guy about the Twins or Vikings, and usually he's following and knows some stats. Ask him to fix a mechanical what's-it, and commonly he can figure it out. But ask a guy about how many calories are in the biscuits and gravy on his plate, and you'd think you were expecting him to know how to sew on a button or plan a shopping trip. It's amusing to kid around about manly men's stereotypes, but it's no joking matter that eating too much food and too many calories can bring on a heart attack, stroke, or cancer, or early death. And men are usually the big eaters. We find rats live about 40% longer when they're fed about 40% less. And we think humans work the same way. It seems the rats who are on the eat anything and everything you want diet die prematurely, just like humans. Researchers believe those vascular and malignant medical problems are due to premature oxidation, which is, in turn, due to excessive calorie intake. You reduce that oxidative load not by antioxidants, but by eating less. We're not just talking about obesity. We're talking about learning to eat right. Obese or not, we need to realize that having seconds and thirds, constant snacking, ordering high-calorie foods, drinking non-satiating sugar or alcohol drinks, all can be poisonous. Plain and simple, too many calories are dangerous to your health. Dietary experts have defined a normal-sized man's total goal for a full day of eating should be about 2,000 calories, and to lose weight about 1,500. Not surprisingly, a single fast food meal often approaches our entire daily caloric need. For example, a loaded Big Burger with bacon, large fries, and a 12-ounce soft drink adds up to 1,334 calories. Try this. Ask your smartphone how many calories are in each portion of food you eat for 3 days. Or write it down, keep track, and add up your daily count. Ask for help if you need it. Knowing calories in food will help you eat less. Indeed, men in general usually don't eat enough fruits and vegetables, but the most important error in their modern diet comes from eating too many calories. And by the way, there are about 400 calories in a single order of biscuit and gravy. We send a big thank you to our guests tonight. Ken Bartholomew and Eugene Park for volunteering their time to travel to our studio and appear on our show. Remember, the annual flu season is upon us. If you've not done so already, do not delay. Get your flu vaccine now to reduce your chances of catching that flu bug. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Funding for On Call at the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. In the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota State Medical Association, Aberdeen Asthma and Allergy, Avera Heart Hospital, Dakota Bank, Dakota Allergy and Asthma, Fishback Financial Corporation, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Swiftel Communications, and Vance Thompson Vision.